Dr. Hobbs, can you walk us through how ET is really diagnosed?
Yeah, so ET can be diagnosed in several different ways. So generally, patients come to medical attention for several different reasons, and it can really vary. So patients can present to their, primary care doctor, get a blood count checked, and then the primary care doctor realizes that the platelets are elevated. And that's, I would say, how patients most frequently are diagnosed. Now, sometimes patients can also have symptoms that can be attributed to the platelets, and that can lead them to seek medical attention, whether that be a blood clot, or they may have headaches that they didn't have before, or maybe they have what we call microcirculatory symptoms, like, for example, issues with circulation in the tiniest vessels, which can lead to kind of numbness and tingling in the hands and feet, or other symptoms. But in terms of the official way that we diagnose ET, having high platelets by itself is not sufficient because there are other conditions that can also lead to high platelets that are not ET. And the word essential and essential thrombocythemia kind of implies that the problem in ET is primary, meaning it is an issue of the bone marrow, not an issue of anything else. So ET can be diagnosed following criteria that we use from the World Health Organization, and that requires that patients have high platelets, but also that they have a mutation in either JAK2, calreticulin, MIPL, or other, and that they also have a bone marrow biopsy where the morphology, or what the cells look like under the microscope, is consistent with the diagnosis of ET. There are other MPNs, or myeloproliferative neoplasms, that share these same mutations. And so having that bone marrow biopsy is helpful to distinguish between the different MPNs. And so important to remember, many conditions can cause high platelets. And so it's important to meet all of these criteria to ensure that a patient actually has the correct diagnosis.
That's excellent. Can you share a little bit about what next generation sequencing is? We've had some patients ask about that. So if you could just give a better explanation for us, that would be fantastic.
Yeah, absolutely. So there has been a significant evolution in the tests that we have available to identify genetic mutations, or these small errors that occur inside of the DNA of the blood-forming stem cells. And we can find these mutations by either doing a test that just looks for a mutation in JAK2, or we have these more advanced techniques called next-generation sequencing, where we can sequence the genes of interest, like, for example, JAK2, CALR, or MIPL, and others with significant precision, so being very accurate, and where we can identify, tiny amounts of these mutations. And so basically next generation sequencing, or NGS, just refers to a way of sequencing, meaning to read the actual makeup of the DNA of these genes with significant accuracy. And so that helps us to be able to diagnose patients more easily and more accurately. And interestingly as well, NGS has become significantly cheaper and is much more widely available now, which is very helpful for the diagnoses of these conditions and other blood conditions.
Excellent. That's super helpful. Another question we get from patients is their variant allele fraction. Can you explain what a VAF really is and what that measures?
Yeah, great question. So the variant allele fraction, or VAF, basically is a way of helping us to estimate how many of those blood-forming stem cells in the bone marrow have the mutations and how many do not. And so I think an interesting concept is that in a patient that has essential thrombocythemia, for example, not all of the blood-forming stem cells in the bone marrow actually have the mutation. So there's part of the bone marrow that's healthy and that has normal blood-forming stem cells, and there may be a part of the bone marrow that has stem cells that have those mutations. And so the variant allele fraction is kind of a quantitative way where we can estimate the amount of blood cells that have that VAF. Over time, it would be wonderful if our therapies would consistently change the level of the mutation, or the VAF, variant allele fraction, and that we can measure that over time to tell our patients how they're doing on treatment. And there's a lot of interest in that, but we're not quite there yet. Some of our medications can do that, but I would say not in a way where we can really advise our patients well enough to say, oh, at this time point in your disease, your VAF needs to be this. So we're not quite there yet, but I feel like we will be at some point.